Today we will continue the discussion of acute inflammation and we'll have a look at cytokines and chemokines. Cytokines are proteins secreted by many cell types, principally activated by lymphocytes, macrophages, and dendritic cells, but also endothelial, epithelial, and connective tissue cells. Cytokines mediate and regulate immune and inflammatory reactions. Tumor necrosis factor and interleukin-1 play a critical role in leukocyte recruitment by promoting adhesion of leukocytes to endothelium and their migration through vessels. Activated macrophages and dendritic cells mainly produce these cytokines. Tumor necrosis factor is also produced by T lymphocytes and mast cells, and some epithelial cells produce interleukin-1 as well. Microbial products, foreign bodies, necrotic cells, and a variety of other inflammatory stimuli can stimulate the secretion of tumor necrosis factor and interleukin-1. The production of tumor necrosis factor is induced by signals through TLRs and other microbial sensors, and the synthesis of interleukin-1 is stimulated by the same signals, but the generation of the biologically active form of this cytokine is dependent on the inflammasome. The actions of tumor necrosis factor and interleukin-1 contribute to the local and systemic reactions of inflammation. The most important roles of these cytokines in inflammation include endothelial activation, activation of leukocytes and other cells, systemic acute phase response. Both tumor necrosis factor and interleukin-1 act on endothelium to induce a spectrum of changes referred to as endothelial activation. These changes include increased expression of endothelial adhesion molecules, mostly E and P selectins and ligands for leukocyte integrins, increased production of various mediators, including other cytokines and chemokines and eicosanoids, and increased procoagulant activity of the endothelium. Tumor necrosis factor augments responses of neutrophils to other stimuli such as bacterial endotoxin and stimulates the microbicidal activity of macrophages. Interleukin-1 activates fibroblasts to synthesize collagen and stimulates proliferation of synovial cells and other mesenchymal cells. Interleukin-1 and interleukin-6 also stimulate the generation of a subset of CD4+ helper T cells called Th17 cells. Interleukin-1 and tumor necrosis factor as well as interleukin-6 induce the systemic acute phase responses associated with infection or injury, including fever. They also are implicated in the pathogenesis of the systemic inflammatory response syndrome, abbreviated as SIRS, resulting from disseminated bacterial infection, sepsis, and other serious conditions. Tumor necrosis factor regulates energy balance by promoting lipid and protein catabolism and by suppressing appetite. Therefore, sustained production of tumor necrosis factor contributes to cachexia, a pathologic state characterized by weight loss, muscle atrophy, and anorexia that accompanies some chronic infections and cancer. Chemokines are a family of small proteins that act primarily as chemoattractants for specific types of leukocytes. About 40 different chemokines and 20 different receptors for chemokines have been identified. They are classified into 4 major groups according to the arrangement of cysteine residues in the proteins. CXC chemokines act primarily on neutrophils. Interleukin 8, now called CXCL8, is typical of this group. It is secreted by activated macrophages, endothelial cells, and other cell types, and causes activation and chemotaxis of neutrophils with limited activity on monocytes and eosinophils. Its most important inducers are microbial products and cytokines, mainly interleukin 1 and tumor necrosis factor. CC chemokines mainly serve as chemoattractants for monocytes, eosinophils, basophils, and lymphocytes. Although most of the chemokines in this class have overlapping actions, eotaxin selectively recruits eosinophils. C chemokines are relatively specific for lymphocytes. CX3C chemokines have known member of this class is called fractalkine. This chemokine exists in 2 forms: a cell surface bound protein induced on endothelial cells by inflammatory cytokines that promote strong adhesion of monocytes and T cells, and a soluble form derived from proteolysis of the membrane-bound protein that has potent chemoattractant activity for the same cells. Chemokines bind to proteoglycans and are displayed at high concentrations on the surface of endothelial cells and in the extracellular matrix. They have 2 main functions: acute inflammation. Most chemokines stimulate leukocyte attachment to endothelium by acting on leukocytes to increase the affinity of integrins, and also serve as chemoattractants, thereby guiding leukocytes to sites of infection or tissue damage. Because they mediate aspects of the inflammatory reaction, they are sometimes called inflammatory chemokines. Their production is induced by microbes and other stimuli. The second function is maintenance of tissue architecture. Some chemokines are produced constitutively by stromal cells in tissues and are sometimes called homeostatic chemokines. These organize various cell types in different anatomic regions of the tissues, such as T and B lymphocytes in discrete areas of the spleen and lymph nodes. The complement system is a collection of soluble proteins and their membrane receptors that function mainly in host defense against microbes and in pathologic inflammatory reactions. There are more than 20 complement proteins, some of which are numbered C1 through C9. They function in both innate and adaptive immunity for defense against microbial pathogens. In the process of complement activation, several cleavage products of complement proteins are elaborated that cause increased vascular permeability, chemotaxis, and opsonization. Complement proteins are present in inactive forms in the plasma, and many of them are activated to become proteolytic enzymes that degrade other complement proteins, thus forming an enzymatic cascade capable of tremendous amplification. The critical step in complement activation is the proteolysis of the third component, C3. Cleavage of C3 can occur by one of three pathways. The classical pathway, which is triggered by fixation of C1 to antibody, immunoglobulin M and immunoglobulin G, that has combined with antigen. The alternative pathway, which can be triggered by microbial surface molecules including endotoxin or LPS, complex polysaccharides, and other substances in the absence of antibody. And the lectin pathway, in which plasma mannose-binding lectin binds to carbohydrates on microbes and directly activates C1. The enzymatic activity of complement proteins provides such tremendous amplification that millions of molecules of C3b can deposit on the surface of a microbe within 2 or 3 minutes. The complement system has three main functions: inflammation, abscesses and phagocytosis, and cell lysis. The activation of complement is tightly controlled by cell-associated and circulating regulatory proteins. Different regulatory proteins inhibit the production of active complement fragments or remove fragments that deposit on cells. These regulators are expressed on normal host cells and thus prevent healthy tissues from being injured at sites of complement activation. Regulatory proteins can be overwhelmed when large amounts of complement are deposited on host cells and in tissues, as happens in autoimmune diseases in which individuals produce complement-fixing antibodies against their own cell and tissue antigens. The complement system contributes to disease in several ways. The activation of complement by antibodies or antigen-antibody complexes deposited on host cells and tissues is an important mechanism of cell and tissue injury. Inherited deficiencies of complement proteins cause increased susceptibility to infections, and deficiencies of regulatory proteins cause a variety of disorders. Kinins are vasoactive peptides derived from plasma proteins called kininogens by the action of specific proteases called kallikreins. The enzyme kallikrein cleaves a plasma glycoprotein precursor, high molecular weight kininogen to produce bradykinin. Bradykinin increases vascular permeability and causes contraction of smooth muscle, dilation of blood vessels, and pain when injected into the skin. These effects are similar to those of histamine. The action of bradykinin is short-lived because it is quickly inactivated by an enzyme called kininase. Bradykinin has been implicated as a mediator in some forms of allergic reaction, such as anaphylaxis. Vasoactive. There are several roles for mediators in different reactions of inflammation. Vasoactive amines, mainly histamine, are responsible for vasodilation and increased vascular permeability. Arachidonic acid metabolites, including prostaglandins and leukotrienes. There are several forms exist and are involved in vascular reactions, leukocyte chemotaxis, and other reactions of inflammation, and they are antagonized by lipoxins. Cytokines are proteins produced by many cell types. They usually act at short range and they mediate multiple effects, mainly in leukocyte recruitment and migration. The principal cytokines participate in acute inflammation, and they include tumor necrosis factor, interleukin-1, and chemokines. There are also complement proteins. The activation of the complement system by microbes or antibodies leads to the generation of multiple breakdown products, which are responsible for leukocyte chemotaxis, opsonization, and phagocytosis of microbes and other particles, and cell killing. Kinins are produced by proteolytic cleavage of precursors, and they mediate vascular reaction and pain. The morphologic hallmarks of acute inflammatory reactions are dilation of small blood vessels and accumulation of leukocytes and fluid in the extravascular tissue. The vascular and cellular reactions account for the signs and symptoms of the inflammatory response. Increased blood flow to the injured area and increased vascular permeability lead to the accumulation of extravascular fluid rich in plasma proteins, and this process is known as edema. It also leads to and accounts for the redness, rubor, warmth, color, and swelling, tumor, that accompany acute inflammation. Leukocytes that are recruited and activated by the offending agent and by endogenous mediators may release toxic metabolites and proteases extracellularly, causing tissue damage and loss of function. Funktionsleser. During the damage, During the damage, and in part as a result of the liberation of prostaglandins, neuropeptides, and cytokines, one of the local symptoms is pain, dolor in Latin. Although these general features are characteristic of most acute inflammatory reactions, special morphologic patterns are often superimposed on them, depending on the severity of the reaction, its specific cause, and the particular tissue and site involved. The importance of recognizing distinct gross and microscopic patterns of inflammation is that they often provide valuable clues about the underlying cause. There are several types of acute inflammation: serous inflammation, fibrinous inflammation, suppurative purulent inflammation, and ulcer. Serous inflammation is marked by the exudation of cell-pore fluid into spaces created by injury to surface epithelium or into body cavities lined by the peritoneum, pleural, or pericardium. Typically, the fluid in serous inflammation is not infected by destructive organisms and does not contain large numbers of leukocytes, which tend to produce purulent inflammation. In body cavities, the fluid may be derived from the plasma as a result of increased vascular permeability, or from the secretions of mesothelial cells as a result of local irritation. Accumulation of fluid in these cavities is called an effusion. Effusions consisting of transsudates also occur in non-inflammatory conditions, such as reduced blood outflow in heart failure or reduced plasma protein levels in some kidney or liver diseases. On the picture, you can see the skin blister resulting from a burn or viral infection, and this represents accumulation of serous fluid within or immediately beneath the damaged epidermis of the skin. This is another example of serous inflammation that we just discussed. A fibrinous exudate develops when the vascular leaks are large or there is a local procoagulant stimulus. With a large increase in vascular permeability, higher molecular weight proteins, such as fibrinogen, pass out of the blood, and fibrin is formed and deposited in the extracellular space. A fibrinous exudate is characteristic of inflammation in the lining of body cavities, such as the meninges, pericardium, and pleural. Histologically, fibrin appears as an eosinophilic meshwork of threads, or sometimes as an amorphous coagulum. Fibrinous exudates may be dissolved by fibrinolysis and cleared by macrophages. If the fibrin is not removed with time, it may stimulate the ingrowth of fibroblasts and blood vessels and thus lead to scarring. Conversion of the fibrinous exudate to scar tissue, known as organization, within the pericardial sac leads to opaque fibrous thickening of the pericardium and epicardium in the area of exudation, and if the fibrosis is extensive, obliteration of the pericardial space, constrictive pericarditis. We're going to have a look at a case of constrictive pericarditis that has been published recently in the European Heart Journal in 2019. A 58-year-old man complained of lower extremity fatigue, intermittent chest tightness, and shortness of breath. He was first misdiagnosed as neuropathy, later on successfully treated as ischemic heart disease, though severe stenosis of the diagonal branch of left anterior descending artery was confirmed by computer tomography and angiography. He was finally diagnosed as constrictive pericarditis after carefully reading the initial computer tomography. The gross pathology of heart in situ, originally observed at the time of pericardectomy, indicated fibrinous pericarditis, massive pericardial effusion of 300 milliliters, a thickened pericardium with maximum thickness more than 6 millimeters. Following pericardial tissue biopsy and histopathology showed fibrinous pericarditis without a clear etiology. His symptoms gradually disappeared after surgical pericardectomy. At the 1-year follow-up visit, the patient complained of no discomfort. So, the initial transthoracic echocardiogram taken after 2 months indicated left ventricular ejection fraction of 72%, fractional shortening of 42%, stroke volumes of 88 milliliters, and cardiac output of 10.9. More moderate pericardial effusion was detected, and the depth of liquid in left ventricular apex was 5 millimeters, and diaphragmatic surface of right ventricle was 12 millimeters. On the picture you see the chest X-ray on admission that shows high density involving both lungs symmetrically and massive pleural effusion signified by the red arrow. Echocardiogram showed small medium pericardial effusion shown by red arrows and thickened parietal pericardium shown by the blue arrow. The electrocardiography of the patient demonstrated sinus tachycardia. The computed tomography showed pleural effusion, mild pericardial effusion, and the thickening of pericardium. The red arrows on these pictures indicate thickening of pericardium. Phorasynthesis of the left thoracic cavity using imaging guidance was performed to determine the cause of the excess pleural effusions and to relieve his shortness of breath. A total of an estimated 1,180 milliliters of fluid was drained from pleural effusion during hospitalization. Laboratory tests of the pleural effusion indicated leakage fluid with the following results. Light yellow turbid liquid, Rivalta test. Total cell count, you can see it on the picture, the monocyte accounting for 90% of total white blood cells, the white blood cell count of 140,000, the protein levels, the glucose, lactate dehydrogenase, and adenosine deaminase. Phorasynthesis of the right thoracic cavity was also performed later. A total of 3,050 milliliters of fluid was drained from the pleural effusion during hospitalization. Laboratory tests of the pleural effusion showed the leakage. And hyperplastic mesothelial cells and lymphocytes were found in the pleural effusion. The following findings came out during the pericardectomy. The gross view of heart in situ, originally observed at the time of pericardectomy, indicated fibrinous pericarditis, massive hemorrhagic pericardial effusion, and thickened pericardium. The maximum thickness of the pericardium is more than 6 millimeters. Black arrows on the picture, on your upper picture on the left, indicate thickened pericardium. White arrows on the same picture indicate hemorrhagic pericardial effusion, and white box, also shown on this picture, indicates massive fibrinous pericarditis. Here, the black arrow on the picture indicates the interior of cardiac pericardium. In this case, patient shows the symptoms and signs of right-sided heart failure, including shortness of breath, pleural effusion, ascites, pericardial effusion, and ankle edema, all of which are non-specific for the diagnosis of constrictive pericarditis. The signs and symptoms of predominantly right-sided heart failure were present with shortness of breath, jugular venous distension, edema, and ascites, which are seen in 62% of the cases of constrictive pericarditis. In this case, decreasing the amount of pleural and pericardial fluid effectively relieved the patient's shortness of breath, but all symptoms reappeared shortly. Constrictive pericarditis should have been considered by the doctors. Pericardial thickness was present in 37% of constrictive pericarditis patients evaluated by echocardiography and 72% by computed tomography. Increased pericardial thickness of 3 mm was observed in all patients with constrictive pericarditis. In our patient, the pericardial thickness was more than 4.5 mm by high-resolution computed tomography and more than 6 mm by directly pathological observation, leading to their diagnosis of constrictive pericarditis. The echocardiogram did suggest the constrictive pericarditis, although it showed a small medium pericardial effusion, an increase in right heart size, dilation of the inferior vena cava, and respiratory variation of the mitral peak E velocity of more than 25% in a patient. The observed signs could also be caused by an existing pericardial effusion, and in this case we diagnosed this is idiopathic constrictive pericarditis associating with large pericardial effusion, though the mechanism underlying it remains unproved. Let's have a look at a different case report of acute fibrinous pneumonia. This is also a clinical case report published in 2019, so it's recently fresh, new. So, a 59-year-old man with no significant medical history was admitted to hospital with a 15-day history of high-grade fever, chills, and no productive cough. He reported no weight loss, night sweats, pet contact history, and recent travels, but a smoking history of 5 years was reported. Before admissions to hospital, the X-ray examination on the chest showed patchy exudation and consolidation. Then the patient received a 13-day course of the antibiotic therapy. However, he did not recover and was transferred to hospital for treatment. The ferretic computed tomography showed bilateral lower lobe consolidation, ground glass opacification shown by the arrows on the CT, and nodules. Therefore, the patient was diagnosed as hospital-acquired pneumonia. On initial examination, he was febrile with temperature of 41. The blood pressure, heart rate, and respiratory rate were 110 over 80 millimeters of mercury, 102 beats per minute, and 23 breaths per minute. On physical examination, the lung auscultation revealed the close breath sounds with fine crackles in the lower lung zones, while other physical examination did not exhibit any abnormality. Laboratory testing showed that white cell count was about 13,000 cells per microliter of blood with neutrophil ratio of 88%. The C-reactive protein was elevated. The arterial blood gas analysis demonstrated pH of 7.44, and the other outcomes you can see on this slide. The symptoms of the patient did not respond to antibiotic therapy. On the 15th day of hospitalization, pulmonary CT scan showed no changes of the lung consolidation, but more reticular patterns in the lower lobe of both lungs. The CT-guided percutaneous needle lung biopsy was performed as a next step. Specimens of the lung biopsy are demonstrated from the left lower lobe. Histological findings in the lung were the following. The biopsied lung shows intra-alveolar spaces containing fibrin deposition, demonstrated by the black arrows, and formation of fresh fibroblast foci as a sign of organizing pneumonia. This is shown by the yellow arrow. Mild chronic interstitial infiltrate and hyperplasia of type 2 pneumocystis were also shown. With the diagnosis of acute fibrinous pneumonia, all the antibiotics were discontinued, and 40 mg methylprednisolone daily was given intravenously. 4 days later, fever, chills, and cough all disappeared. The white cell counts decreased from 12,000 to 8,000 cells per microliter of blood, and the patient was symptom-free at follow-up after 1 month. Acute fibrinous pneumonia was first reported by Beasley and his colleagues in detail as an unusual type of acute lung injury in 2002. It has been reported in all age groups with average age of 62 years. Males are more commonly affected. In 2013, the updated classification of the idiopathic interstitial pneumonia described acute fibrinous pneumonia is considered a rare histological pattern lying within the spectrum of acute subacute lung injury, which is characterized by intra-alveolar fibrin deposition and organizing pneumonia with patchy distribution. The case that we have looked at, the published evidence was insufficient to warrant the recognition as a specific entity. Acute fibrinous pneumonia diagnosis should be made only on large biopsy specimen. The differential diagnosis should include the common patterns of lung injury, such as diffuse alveolar damage or eosinophilic pneumonia. Focal areas of intra-alveolar organizing fibrin can be seen in diffuse alveolar damage, but those of lung showing coexistent hyaline membranes are not observed in acute fibrinous pneumonia. Moreover, fibrin deposition in acute fibrinous pneumonia is more prominent, and the typical pathological changes of diffuse alveolar damage become more diffused. The pathology of organizing pneumonia lacks the coexistent fibrin deposition. Finally, acute and chronic eosinophilic pneumonia may have prominent intra-alveolar fibrin, similar with that in acute fibrinous pneumonia. Eosinophilic pneumonia is characterized by the predominance of eosinophils, sometimes termed as eosinophilic microabscesses and macrophages. The macrophages may vary in number, but the eosinophils predominate. The interstitium also contains abundant eosinophils within the inflammatory infiltrate. In conclusion, acute fibrinous pneumonia is a rare lung disease characterized by bilateral bacillar infiltrates and histological findings of intraalveolar fibrin in the form of fibrin balls. Lung biopsy and histopathology, which were the most important diagnostic methods, should be performed. Okay, we're going to look at the third case report published in Respiratory Medicine volume, and this one is slightly older and it comes from 2008. A 26-year-old woman was admitted to the hospital after experiencing fever, cough, and shortness of breath for 1 week. The patient had been well until 1 week before admission, when the fever began. She did not have chills, but she did begin having a non-productive cough, and shortness of breath worsened after physical activity. The temperature fluctuated between 38 and 39. Shortness of breath occurred by lying down and worsened by any sort of movement after admission. A chest radiograph showed bilateral diffuse and reticulonodular opacities. A ferretic computed tomography scan disclosed diffuse patchy exudation and reticular high-density opacities with obscure boundaries and an obstructed lower bronchus. The shortness of breath worsened gradually and presented progressive hypoxic respiratory failure despite undergoing a series of therapies. These therapies included anti-infection, oxygen inhalation, spasmolysis, and enhanced nutritional support. The clinical diagnosis of acute interstitial pneumonitis was made primarily on the basis of short course and rapid violent progression of the disease. Although she underwent large dose prednisolone and mechanical ventilation treatments followed after the diagnosis, dyspnea became more serious with progressive hypoxemia, which was indicated by blood gas analysis. Respiratory and cardiac arrests occurred on the 20th day after admission, and despite immediate rescue remedies, the patient died. During the autopsy, there was no cervical supraclavicular lymphadenopathy noted. The thyroid was normal. The lung expansion was symmetric bilaterally. No wheezes or rhonchi noted. The heartbeat was tachycardic. There was no murmur, clicks, or rubs. The abdomen revealed normal active bowel sounds. There was no rebound or guarding. The liver and spleen were not palpable. And there was no evidence of clubbing or cyanosis. There was no femoral, axillary, or epitrochlear lymphadenopathy noted. To make a definite diagnosis, an autopsy was performed. The autopsy indicated both lungs weighted 1,400 grams. The left and right lung volumes were 22 over the 13/5 and 22/13/7 centimeters respectively. Both lung surfaces were smooth and glossy, and a small amount of fibrinous adhesion was found among the pulmonary lobes. Its cross-section showed Kermes sinus with some red liquid matter leaking out. Its texture was hard. Microscopical examination showed diffuse marked alveolar septal edema with fibroblast proliferation, collagen fibrillation, lymphocyte infiltration, and occasional hyaline membranes. The septa were lined with hyperplastic cubic alveolar epithelial cells, more exudation and phagocytes in alveolar space, bronchial epithelium autolysis with occasional squamous metaplasia, significant arterial vein ectasia and congestion, and hyperplastic pulmonary endarterium. Tongue-shaped hyperplastic type 2 pneumocytes filled some air spaces and collapsed, and organized thrombi developed in the small arteries. In addition to her clinical history, the results of the autopsy were consistent with pathological changes of acute interstitial pneumonia. In conclusion, could be said that the patient died of progressive respiratory failure caused by pulmonary interstitial fibrosis. In 1944, Hammerich described a group of patients with rapidly progressive respiratory illness and unknown etiology. All patients experience insidious onset followed by a cough, respiratory embarrassment, and respiratory failure, and progressive pulmonary interstitial fibrosis in both lungs. They all died within 2 to 6 months of initial onset. In addition, sections from their post-mortem lungs indicated pulmonary edema with areas of hyaline membrane formation and diffuse and hyperplastic septal fibrous tissue. With these conditions, term acute diffuse interstitial fibrosis of the lung was introduced. In subsequent publications, the eponym Hammerich syndrome has been used to describe the cases of diffuse pulmonary fibrosis. This case that we just considered is interesting from a clinical point of view because we can see simultaneously morphological features of acute and chronic inflammation in the same patient. The purulent or suppurative inflammation is characterized by the production of pus, an exudate consisting of neutrophils, the liquefied debris of necrotic cells, and edema fluid. The most frequent cause of purulent inflammation is infection with bacteria that cause liquefactive tissue necrosis, such as staphylococci. These pathogens are referred as pyogenic pus-producing bacteria. A common example of an acute suppurative inflammation is acute appendicitis, and we'll have a look at the publication from 2009, and in particular the case of acute appendicitis. A 24-year-old female who presented to the accident and emergency department with a 4-hour history of right lower quadrant abdominal pain. The pain originated in the umbilical region, radiating diffusely across the lower abdomen and subsequently localized to the lower quadrant abdominal pain. The pain was a sudden, sharp, and colicky with progressive intensity. Over-the-counter oral cocodamol 500 milligrams. It's a combination of analgesic of codeine phosphate and acetaminophen. Was taken before presenting to emergency department. However, it did not alleviate the pain. The pain was exacerbated by lifting the right leg and relieved by leaning forwards. Severity was rated 8 on a scale of 1 to 10, with 1 being no pain and 10 being the most pain possible. This episode has not been preceded by previous abdominal pain, and the patient denied nausea or vomiting. She opened her bowels post-onset of the pain with no changes to the consistency of the stools and absence of blood or mucus. The patient denied urinary or infective symptoms. Past medical and surgical history was nil of note. Drug history included the oral contraceptive pill with no known drug allergies. There was no relevant family history. Based on clinical presentation of patient, the initial impression pointed towards a provisional diagnosis of acute appendicitis with ovarian cyst as a differential. Subsequent investigation revealed a negative urine dip and negative pregnancy test, which deemed a gynecological cause unlikely. Blood results were all within normal ranges. Abdominal ultrasonography confirmed the diagnosis of appendicitis by the presence of free fluid and within the 6 mm appendix, which was incomprehensible. These findings were in keeping with appendicitis. A key point to note is the location of the appendix was a variant of the anatomical norm. It was visualized as the level of the right lever, indicating a subhepatically located appendix. This finding revised the diagnosis to subhepatic appendicitis. A surgical report included the following: a laparoscopic appendectomy was performed under general anesthesia with the following ports: umbilical, left iliac fossa, and suprapubic. Reporting on the operation, the small bowel was dilated from the terminal ileum to proximal jejunum. The caisson was lying at the hepatic flexure, and resultantly the appendix base was posterior-inferior to the inferior border of the liver. This was attributed to a congenital adhesion causing malrotation of the caisson pole. The appendix was enlarged. This is shown by an arrow on the top right. Serous fluid was present in the pelvis and right upper quadrant. Other than these observations, the sigmoid colon, uterus, ovaries, and fallopian tubes were normal. Upon discovering the anatomical variant, the adhesions were divided, caisson returned to the appropriate position in the right upper quadrant, and the appendix mobilized. There was diathermy and division of the appendicular artery. The appendix was divided and removed via the umbilical port. Finally, washout to the right upper quadrant and pelvis was performed and aspirated. Following surgery, patient was stable and recovered well with mild bloating and tenderness. The histological investigation demonstrated necrosis in the appendix with neutrophil infiltration, shown by the arrow. The patient was discharged with no prescription medication or follow-up required. Abscesses are a localized collection of pus caused by suppuration buried in a tissue, an organ, or a confined space. They are produced by seeding of pyogenic bacteria into tissue. Abscesses have a central region that appears as a mass of necrotic leukocytes and tissue cells. There is usually a zone of preserved neutrophils around this necrotic focus, and outside this region there may be a vascular dilation and parenchymal and fibroblastic proliferation, indicating chronic inflammation and repair. In time, the abscess may become walled off and ultimately replaced by connective tissue. When persistent or at critical locations such as brain, abscesses may have to be drained surgically. Let's consider a case report of primary LAN abscess. In April 2018, a 69-year-old man with a history of diabetes mellitus and chronic kidney disease and undergoing dialysis treatment was admitted to hospital after complaints of slight bloody sputum for the past 7 days and weight loss of 5 kilograms in the past 6 months. On admission, he was afebrile and did not present with respiratory distress. The vital signs of the patient were normal. Auscultation revealed clear respiratory sounds, and other physical examinations also yielded unremarkable findings. However, blood tests revealed elevated white blood cell count and C-reactive proteins level. A computed tomography scan of the chest showed multiple consolidations with cavities in both lung fields. The patient had routine chest X-rays every 3 months due to ongoing dialysis treatment to check his cardiothoracic ratio, and the chest radiographs from 1, 4, and 6 months ago also showed multiple interstitial infiltrations. The locations of these infiltrations were consistent with the lung abscesses revealed by the computed tomography on admission. These results indicated that the abscesses had existed for at least 6 months. The patient was hospitalized based on the diagnosis of multiple lung abscesses. To determine the causative pathogen, the bronchoscopy was performed. Gram stain of bronchoalveolar lavage fluid showed only capsulated gram-negative rods, and the microorganism was identified as K. pneumoniae by conventional methods, and this particular microorganism is shown by the arrows. Strain test of the isolate was positive, which is characteristic of the hypermucoviscous phenotype. Generally, hypervirulent Klebsiella pneumoniae strains cause community-acquired liver abscess, and diabetes mellitus is a significant risk factor for acquiring hypervirulent Klebsiella pneumoniae infection. Hypervirulent Klebsiella pneumoniae also tends to cause metastatic infections, with the most common sites being the eyes and central nervous system, occurring in approximately 1/3 of the patients. Lung abscesses have also been found to occur as a result of metastatic or invasive infection from primary infectious sites. However, primary lung abscess due to the strain is extremely rare. We'll consider another case of an unusual lung abscess. A 56-year-old woman attended casually. She was casually complaining of right-sided, sharp, non-radiating chest pain, aggravated by deep breaths and movement. She also had a history of shortness of breath on menial exertion, a low-grade fever with chills, a cough with foul-tasting sputum, and 10-kilogram weight loss over the preceding 2 months. 8 days previously, she had been seen in the respiratory clinic for the above-mentioned symptoms, all of which started after she underwent a laparoscopic cholecystectomy and cholangiogram for multiple symptomatic gallstones. She has been started on a short course of coamoxiclav by her general practitioner, which helped reduce the amount and frequency of her sputum production. When she was examined in the respiratory clinic, she was afebrile, non-tachycardic or tachypnoic, and her chest was bilateral air entry without additional sounds. The heart sounds were normal. Investigations showed a normal hemoglobin, white cell count, neutrophils, lymphocytes, monocytes, and xenophils, erythrocyte sedimentation rate of 18, and C-reactive protein. And you can see the results of laboratory investigation on the slide. A chest radiograph revealed a large cavitating mass with a near fluid level in the right upper lobe, suggestive of a lung abscess. She was started on a 6-week course of oral antibiotics with a plan to repeat her chest X-ray in 1 week. Sputum samples were requested and an appointment was made for outpatient bronchoscopy. Blood tests showed an elevated white cell count, neutrophils, and eosinophils. The chest X-ray revealed that the cavitating mass in the right upper lobe had increased in size. The computed tomography of the chest showed the right upper lobe cavitating lesion with an air fluid level shown by an arrow and a moderate right pleural effusion, suggesting a rupture of the abscess into the pleural cavity. A large bore chest drain was inserted with thick yellow fluid being drained from the pleural space. The pleural fluid pH was 6.9 and the fluid was sent for microbiological tests. The histopathology of the bronchial alveoli showed the presence of eosinophils and charcoal-laden crystals and multiple yellowish, brown, or peculated eggs measuring approximately 140 over 80 nanometers. Pathognomonic for fasciola. Fasciola is a common trematode infection found worldwide. It was the first trematode to be described in 1379 by the Brie. Fasciola hepatica, the sheep liver fluke, is found across temperate and subtropical countries in Europe, the Middle East, Central and South America. And Fasciola gigantica, the cattle fluke, is more common in Southeast Asia and Africa, and the two can coexist. Humans are the accidental hosts. Infection occurs due to consumption of watercress and other aquatic plants growing in water contaminated with animal feces. Unembryonated eggs are laid into the water by infected sheep. The eggs embryonate in water and the larvae enter the snails. The cercaria leave the snails and insist to form metacercaria, which attach to the aquatic vegetation, which is then consumed by sheep and sometimes humans. The metacercaria exist in the duodenum. In the acute stage or hepatic stage, the parasite larvae then pass through the wall of the intestines into the peritoneal cavity through the hepatic capsule into the liver. The larvae reside in the hepatic parenchyma and cause cavitation, cysts, and hepatic tracts. The host usually suffers from fever, on and off, right upper quadrant pain, urticaria, and tiredness. They have anemia, eosinophilia, and may have transaminitis. The larvae then migrate to the bile ducts and can cause severe inflammation of the biliary tree, causing repeated attacks of cholecystitis or cholangitis. Some patients may be asymptomatic for years in this stage, whereas others may have recurrent attacks. The larvae mature to form flukes, which lay eggs, which are then excreted in bile and eventually the stools. Rarely, the flukes migrate outside the liver and may reside in other organs, like the abdominal wall, lungs, heart, brain, skin, muscles, and the genitourinary system. An ulcer is a local defect or excavation of the surface of an organ or tissue that is produced by the sloughing shedding of inflamed necrotic tissue. Ulceration can occur only when when tissue necrosis and resultant inflammation exist on or near its surface. It is most commonly encountered in the mucosa of the mouth, stomach, intestines, or genitourinary tract. On the picture you can see the intestines. And the skin, as well as subcutaneous tissue of the lower extremities in older persons who have circulatory disturbances that predispose to extensive ischemic necrosis. Acute and chronic inflammation often coexist in ulcers, such as peptic ulcers of the stomach or duodenum and diabetic ulcers of the legs. During the acute stage, there is intense polymorphonuclear infiltration and vascular dilation of the margins of the defect, also shown by the arrows. With chronicity, the margins and base of the ulcer develop fibroblast proliferation, scarring, and the accumulation of lymphocytes, macrophages, and plasma cells. We are going to have a look at a case of peptic ulcer, and this particular case was published in 2018. A 23-year-old male visited a clinic with complaints of an upper abdominal pain, heartburn, nausea, and sometimes vomiting. He was in usual state of health 5 days back when he started having epigastric pain. Pain aggravated at night after taking large meal. He was fond of fried and spicy food. He had a family history of peptic ulcer disease, and patient denied cigarette smoking. These are the results of the general examination of the patient, and you can see the patient's weight, height, BMI, temperature, and blood pressure. According to the provided information, patient's laboratory tests were received and there were no signs of bleeding as hemoglobin values were normal. There was absence of blood in stool, and the patient didn't have vomiting. Serological and urea breath test confirmed Helicobacter pylori positive infection in the patient. The patient suffered from peptic ulcer disease due to many reasons that include improper diet, spicy food, late night meals, family history of ulcer disease, and stress that worsen ulcer symptoms. Patient was at the level where Helicobacter pylori infection needs to be cured. According to research, if symptoms of peptic ulcer are not treated, this may lead to complications like bleeding, perforations, narrowing, and obstruction. Peptic ulcer patients can manage the symptoms by adhering to medications. Lifestyle modifications along with adherence to medications are extremely important for the outcome of this disease. Spicy and late night meals should be avoided. Due to poor dietary habits and sedentary lifestyle, patient faces difficulty in changing his routine. Proper counseling usually improves the patient's disease education and motivates to follow the instructions. Although this might be expected, many variables may modify the basic process of inflammation, including the nature and intensity of the injury, the site and tissue affected, and the responsiveness of the host. Acute inflammatory reactions typically have one of the three outcomes: the complete resolution, healing by connective tissue replacement, the scarring of fibrosis, and progression of the response to chronic inflammation. In a perfect world, all inflammatory reactions, after they have succeeded in eliminating the offending agent, should end with restoration of the site of acute inflammation to normal. This is called resolution and is the usual outcome when the injury is limited or short-lived, or when there has been little tissue destruction and the damaged parenchymal cells can regenerate. Resolution involves removal of cellular debris and microbes by macrophages and resorption of edema fluid by lymphatics. Healing by connective tissue replacement occurs after substantial tissue destruction, when the inflammatory injury involves tissues that are incapable of regeneration, or when there is abundant fibrin exudation in tissues or in serous cavities that cannot be adequately cleared. In all these situations, connective tissue grows into the area of damage or exudate, converting it into a mass fibrous tissue. The third outcome is a progression of the response to chronic inflammation. Acute to chronic transition occurs when the acute inflammatory response cannot be resolved as a result of either the persistence of the injurious agent or some interference with the normal process of healing. We will continue discussing these subjects during the coming class. Thank you for your attention.